Sure. So I'm going to answer this from the point of view of the experience in Oregon. And Oregon is one of the states that is looked to as being a leader in healthcare transformation. And it's been interesting to me sitting in this conversation for the last day and a half that we really haven't talked much about the conversations about transformation that at least so obsess us in Oregon. Maybe it is just an Oregon phenomena, but about a year or 2 years ago, Oregon, for its Medicaid population, adopted this concept of coordinated care organizations. Basically, it's like regional health authorities that were to get all of the funding for physical health, mental health, dental health into one entity that would then be responsible for the care of the Medicaid population in a given region. So we have four previous health plans, 3 mental health plans, 8 dental health plans now in one organization. And the reason they could get these very competitive organizations all together was that we were threatened with a 30% rate cut. And basically the governor in the Great Recession had to deal with, the legislature had to deal with a budget shortfall, and the way they did it, they said, well, we just can't take all the money from education, corrections, and give it to healthcare. What we're going to do is we're going to take the money, less money in healthcare, give it to the CCOs, give them freedom to transform care so they'll be able to do things better at lower cost and still fund the social services. And so the urgency of that brought everybody to the table, because the only way you were going to get funded, even the 30%, with the 30% reduction, was to be in a CCO. Long conversation, very interesting conversation, but what was interesting about it was the sense of urgency really changed CEO behavior. I mean, you're facing a 30% rate cut. That's a lot of money, even in the Medicaid system. And so suddenly, people who had been historic competitors in the market were sitting down at the table and trying to figure out how they were going to create a legal entity where they would work together and have a global budget together. And one of the interesting things was, one of the early conversations was, we need data. We can't do this without data. And the urgency of the situation has changed because the governor was smart enough to go to the feds and say, look, I've got the future of healthcare happening in Oregon. Can you give me some extra dollars? And then we got $2 billion, which made the urgency evaporate. But the conversation has continued, and there has been, and what I learned from that is that push comes to shove, and when you have a sense of urgency around healthcare, which you can decide whether you think that is still coming. We're lucky this year, I think, 3.2% increase in the trend rate. If you believe that will go on forever, Patricia's already laughing, then fine, but I think we're going to be back to, maybe it's not 30% rate cuts, but I think we're going to be back in those really tight situations where people are going to be looking for help in answering, where do we go? Where do we find the 30%, the 10%, the 15%? Where are we going to find that? What are the systems that are going to answer that for us? So the CEO appeal, I think in part is, I think as everybody has said, they're very pragmatic, they want answers quickly, and I think if somebody if a community has the ability to help us deal with information systems and can bring us answers, that will be extremely valued. It took us a year to aggregate the information from all these different health systems, so we now have a big data system, which quite honestly, really nobody knows what to do with. I mean, we get the usual answers, we can ask, we can do the usual queries, but we have this really massive amount of data, and we need people who know how to deal with that and what to do with it. And we don't know where to look. We actually have a job open, if anybody's interested in a job, to help us as a medical director, find a medical director, an informatics person who can help deal with that. Because really, I mean, we have the CEO of Kaiser sitting at our board saying, well, you've got this great thing, you built it, congratulations, tell me what it says. And so the question is, well, what questions do you want answered? And I don't think the CEOs know what questions, but they want the kinds of answers that tell them how to make the system efficient. So for the first question, CEO appeal, CEOs and all of us who live around the C-suite, we have a line of people who come with great ideas, who are trying to sell us things. And so researchers could be in that line and asking for money, but I think you've got to have something really substantially of value. What appeals to CEOs, what we hope appeals to CEO in the world of healthcare transformation, is really not new interventions. It's how do you manage a global budget? How do you integrate mental health and physical health? What are those models of care? What are those systems of care? I mean, reflecting on all the conversation we've had in the last day and a half, we have a lot of knowledge that we're not using. Do we need to generate more knowledge that we won't use? Or do we need to figure out how we use the knowledge we have? And I think from a health system point of view, if we could mobilize what we know in an efficient and effective way, we would be way further down the pike than if we keep investing in creating new knowledge that we don't know how to deploy. So that, I think people want to hear that. I think Brent James did a great job about the infrastructure element. I mean, I think the thing to take away from Brent's work is he built the infrastructure, and that was wonderful. I build infrastructure. It's like his tagline on his card, I build infrastructure. Well, can you help us build infrastructure? One of the realities CEOs deal with is that they deal with really complex systems. I mean, I think Pete Knox's presentation really illuminates what is rare in the world, which is a really high-performing health system which has an extreme amount of intentionality. The number of those systems is very small given the number of systems that exist. Can the research community, who can help systems build those intentional infrastructures that Brent has created at Intermountain and that Pete and his company are building at Bellin? So that's what CEOs need. And it may be research and it may not be research. I think given what we see in the market, most of the CEOs, most organizations are going towards lean and process improvement. They're building it like Pete's building it. They're not building it out of research. Not that they shouldn't, but that's not what they see. That's not what they go to first. And even the Denver Health presentation, the kick line at the bottom was, this is all based on lean. So lean has really taken over what people think in terms of infrastructure and healthcare, and how does the research world connect with the QI and the lean world? How do you connect with each other, and how do you create that common infrastructure? One of the obstacles, I think, for CEOs is that they live in this, but they most of all live in this transitioning world, this moving from fee-for-service, the world of volume, to the world of capitation and value. It is a very confusing world to most CEOs, and many of the organizations that we work with are floundering because their old structures, their old organizational structures do not work. It is no longer a question of simply providing services. The idea of being accountable for a population is really new to organizations, and they don't have structures, they don't have the staffing, they don't have the ability to do that. Can you help, right? That is really the question. So the idea that there could be a partnership with researchers who can help around systems of care is really compelling. I think that's the edge. It sort of feels like the interventional research, which we need to continue to do, was sort of the expertise of the 20th century. The expertise of the 21st century has to add on the system of care research. How do we find that? Who helps us build that? What does it look like? I think it does answer some of those questions about what are the models of care. And I was going to take a little bit different tack on this, patients and families. I work in the Medicaid world. So for us, one of the things that we were charged as CCOs to do was to focus on high utilizers. And it's really become about segmentation, how you segment the population. And those who read the Harvard Business Review probably have read Michael Porter's work on segmentation. So really these systems of care really have to be customized to the patients and the families. So we really have to know what segments of the population need. And I think Sally did a great job. Her quote was, the persona-based design. I don't know where you got that. I'm going to take that back. Persona-based design sounds like a... Yeah, is there? Oh, great. But the issue of how you design for subpopulations, we know the issue. We know the concept of the ambulatory ICU, the AICU. We have focused on these high utilizers. When we started this, we applied for a CMMI grant. We called them high utilizers. What we have learned is that they're really not high utilizers. What they really are is people who have been marginalized for generation after generation, who have lived in poverty, who had adverse childhood events, who failed in school, who failed in employment, who failed in relationships, who self-medicated, who are extremely traumatized and act exactly as you would expect a traumatized population to act. And that what we need is is really a trauma recovery program. So our medical home for that population is a trauma recovery program. So we are putting dialectical behavioral therapy, usually a modality that's used in mental health, in primary care clinics for group visits. So that's a kind of, and the piece that we have just really realized we need to do is we need to bring peers into this conversation. This population has has no connection to community. We need to help them reconnect with community, and that is reconnecting with peers. And there's Oregon actually has now certification for peer wellness specialists, and we're trying to make peers, that is patients and families, part of the workforce of healthcare, right? An intentional part, a paid part of the workforce. Now that may only apply to Medicaid. My suspicion is it doesn't. But how do we think about the work for the healthcare workforce as including patients and families? So so I think that the challenge to meet the population health metrics that we need.
David, you asked me to remind you when you needed to quicken the pace.
Yep, good. Yes. That point made. I think strategies for the board, people have spoken to that. I think the board is interested in cost. The board will be interested in meeting the contracting needs to meet contracting budgets. I think on the policy thing, I think the opportunity here is for PCORI to come up with a new research agenda and new ways to fund research. I think that's what's needed. What is the agenda for the 21st century for research that helps us with healthcare transformation? And finally, the measures of success, I would say, you could track the number of studies that both there's interventional studies and system of care studies. Personally, I would like to see the GDP the healthcare GDP be less than 16%, and that other 2% go into social services. If we can get there, I think that would be great.
Thank you very much, David. Patricia?